All right, I'm going to go ahead and get started as people trickle in. The next panel, as I announced before our break, is the discussion of the safety and efficacy of the COVID-19 vaccine or injection, based on how you interpret it. Our first panelist this afternoon, or actually, are we still in it's still morning, can you believe it, is Stephen Kirsch, and he is joining us today through the love-hated platform of Zoom. He is a philanthropist and executive director of the COVID-19 Early Treatment Fund. He's the inventor of the optical mouse and one of the first internet search engines, InfoSeek. As the founder of 7 high-tech companies, 2 with billion-dollar market caps, Steve is currently focused on safe and effective ways to end the pandemic. He received a BSMS in electrical engineering and computer science from MIT in 1980. Steve, I'll hand it off to you. Hang on one second, Steve. We cannot hear you. And let's see if I can find where Julie is. Hold on one sec. We can't. Well, I can see the microphone moving. Hold on one sec. I'm going to grab Julie. Yeah, or if anyone from Amy can help me.
Okay, can you hear me now?
Yes, we can. That's perfect.
Awesome. Okay,
Yep.
I forgot to unmute before I shared my screen. So let's go back here. And I have about 15 minutes?
Yes, 15.
15. Okay, great. So I'm going to try to give you everything you need to know about vaccine safety in 15 minutes. So, I think the big point here is that nobody's paying attention to the elephant in the room. And what I mean by that is that it's an adverse event known as death. And people tend not to recover from death. And it turns out that we're killing more people than we're saving. So if you look at the number of people that we've killed, I've got 8 different ways to derive over 150,000 Americans have been killed by these vaccines, and nobody has challenged that. And if you look at the number of people that we expect to save from vaccinating 200 million or so people, according to Pfizer's own study, it's 10,000 people that we can save over the next 6 months. So killing 15 people to save 1 person makes no sense. This is the elephant in the room, and this is why nobody likes to talk about the elephant in the room. So what's interesting is that there are fact checkers that go and claim what I'm saying is false, but nobody's able to attack either the data or the methodology. And if you have to attack me, you have to pick the data, the methodology, or both. And none of the fact checks that are out there on the internet address either one of those. That's pretty troubling. Nobody wants to debate me on camera either. That's troubling too. Not the FDA, not the CDC, not their committees, nobody. Nobody wants to debate me on camera about the elephant. Even worse is that the vaccines are killing more people than they say for all age groups over a 6-month efficacy period. So here's the chart. And I derived the numbers, and nobody has challenged the numbers. Not a single person has challenged these numbers and said, no, these are the correct numbers. Because they can't. These numbers are derived using the CDC's own methodology. And you can see that for every age group, the younger you are, the more people we kill versus the number of people saved. So therefore, it is nonsensical to vaccinate any age group, and mandates are unethical. I mean, you can't even talk about anything else. You don't even have to talk about myocarditis. It makes no sense just on deaths alone. And to make matters worse, if that's not bad enough, it's all for nothing. In Israel, the vaccines are making no difference in protecting people from being infected. which is the core use case. This is why they were designed. They were designed to reduce the number of people infected. But in Israel, it's making no difference. And they're the most vaccinated, or one of the most vaccinated countries on earth. 3 vaccines for everyone. And look, there's no benefit. The claim benefit was 95%. The actual benefit is 0. And the US, trusts the Israeli data. They trust the Israeli data more than they trust our own data. Here it is, black and white. Now, so what happened is they changed the story. They had to say the vaccines help prevent you from dying if you get infected. That's the new story now. But it's not true either. If you're under 50, the vaccines make you more likely to die if you get infected. These are the numbers from the UK government that nobody wants to talk about. These are the official UK government numbers. Highly vaccinated country. And it shows that you're more likely to die if you get infected, if you've been vaccinated. So not even that is true. And in fact, if you look at Pfizer's own phase 3 study, you have to read, actually I have to read the study because they don't tell you this in the abstract, and people tend not to read all the pages in the study because it's buried in one sentence. It's one sentence in this that's buried that says basically, more people died who got the vaccine than who got the placebo. And by the way, after we unblinded, then the 5 people that got the vaccine died, but nobody who got the placebo died. So you have a total of 14 deaths in the placebo group who got nothing. And in the vaccine group, you have 20 deaths. In other words, the vaccine kills more people than it saved. Even in Pfizer's own study, they proved that. So I'm going to list my 9 inconvenient truths. So we estimated over 150,000 excess deaths, and we did it 8 different ways to make it bulletproof. So we used the VAERS system for one of the ways, but the other 7 ways didn't use VAERS at all. And so people who say, oh, well, you do that from VAERS. Okay, fine. What about the other 7 ways? I mean, I don't have to get into an argument about with you about it. I think our VAERS analysis was right, but I got 8 different ways. And nobody in the entire world has been able to go and attack the 8 different ways. And this guy, Professor Jeffrey Morris, who goes after me all the time. I mean, I have him on email, and it's recorded in on a Rumble video showing that he admits he's clueless about the number of deaths. He has no idea. He doesn't know whether it's 0. He doesn't know whether it's 150,000 or anywhere in between. He has no idea. So how can he know I'm wrong? He has no clue. And he's my number one opponent. He has no clue how many people have died. The numbers that I'm giving you have been validated in the peer-reviewed medical literature, because people always say, oh, you're not a scientist. But the numbers have been validated in multiple papers. And I'll go into that. The next thing is the CDC is lying to people that there are no deaths from the vaccine. And I'll go into that as well. Nobody can show us a more accurate way to estimate the number of excess deaths. Nobody from the CDC, FDA, or the respective outside committees will agree to a public discussion on the matter, despite the public demand for this. And even Pfizer, we've contacted VPs of Pfizer to say, will you provide a single person to debate me or debunk me? The answer is no. Not even Pfizer itself will defend the claim that nobody has died or attack any of the data that I'm saying. Masks don't work. The CDC says, in fact, on their site, the masks don't work for smoke. Smoke is 25 times bigger than the virus. The virus is 50 to 120 nanometers in size. And cloth masks will filter out 5%. It is nonsensical. It's crazy to be wearing cloth masks. They do nothing. The next point is recovered immunity is always much, much better than vaccine immunity. So, and it makes no sense to vaccinate or require vaccination for anyone who's recovered. I mean, no matter, even if you don't believe anything I've told you, it still makes no sense to vaccinate a recovered patient. And what's really strange is that people who've had COVID or who are naturally immune to COVID are prohibited from being on campus at a corporation or on either a professor on campus. They're not allowed, even though they are way more immune to, less likely to carry the virus than someone who's been vaccinated. This makes no sense either. And then finally, the most important part is that these early treatment protocols are safer and more effective and the smarter alternative to vaccination. And they offer a 99.76 risk reduction without safety issue, and they work against all variants. So, but we're not using them because the NIH says they don't work. This is amazing. Now, this is the vision test. This is used as an employment screen at the FDA and the CDC. If you look at this and you see that there's nothing wrong here, there's nothing going on, you can get a job in safety monitoring for the CDC and the FDA. This is the test they use. This is actually the VAERS number. This is the Vaccine Adverse Event Reporting System, which is the official system used by the US government to track safety signals. They basically don't see a safety signal here. This is just S. They don't see a safety signal here. Now, here's how we know for sure that the CDC is lying to us. This guy named Dr. Peter Schirmacher. He's one of the top pathologists in the entire world. He's the chief pathologist at the University of Heidelberg. He's one of the top 100 pathologists in the world, member of the German National Academy of Sciences. He did an autopsy on 40 people who died within 2 weeks after getting the vaccine. He found that 30 to 40% died from the vaccine, and that's a minimum. Because when you do an autopsy, it's not definitive. You can say, he probably did. So he said, basically, it's a slam dunk, sure thing. I would stake my reputation on it, that at least 30 to 40% died from the vaccine, and it could be 100%. And he's not going to lie. Why would he lie? He has no incentive to lie. He's staking his reputation on it. And it was validated independently by multiple pathologists in Germany. And Norway validated the results as well. So we also have the peer-reviewed scientific literature. Here's one that appeared in toxicology reports a few weeks back. In plain English, people in the 65 plus demographic are 5 times as likely to die from the vaccine as from COVID, under the most favorable assumptions. And it's even worse if you're younger. This is in the peer-reviewed scientific literature. You don't have to believe me. Okay, here's another one in the peer-reviewed scientific literature. 205,809 dead, 212,691 disabled to date. Here's another one in the peer-reviewed literature. Results prove that none of the vaccines provide a health benefit, and all pivotal trials show a statistically significant increase in all-cause severe morbidity, which means you're going to get crippled or disabled for life, or you're going to have heart problems for the rest of your life. So basically concludes mass immunization with COVID-19 vaccines must be halted immediately. Yeah, nobody pays attention to this stuff. More validation. Fact checkers love saying you can't use VAERS for pharmacovigilance. That's nonsense. Here's an editorial by a journal editor saying how nonsensical this statement from the CDC is. Germany found that the boosters were too deadly, even for the elderly. I mean, the boosters are supposed to be used for the elderly. And in Germany, they inoculated 90 people in an old age home, and they found that there was 1 death, 2 resuscitations, so almost 3 deaths, and 9 critically ill with cardiopulmonary symptoms. It's a disaster. They recommended it not be used for boosters for the elderly. And if it can't be used for the elderly, it doesn't make sense for anyone else. Nursing home in Canada, 136 beds, 4 deaths when they gave the booster shot. 4 deaths for every person that they might have saved. Here's an Oahu nursing homes, the two largest nursing homes in Hawaii. They lost over 8% of their residents from the vaccine and less than 2% from COVID. So it's a kill rate of 4 to 1. Again, among the elderly, this is the people that are the ones that has the best use case. A UK funeral director, love it. Never seen anything like it in 15 years as a funeral director. It began as soon as they started putting arms and needle. They were all covered up as COVID deaths. This is why you don't see them. They're all covered up as COVID deaths. The deaths skyrocketed. He couldn't believe what was happening. He was getting multiple calls a day from nursing homes to take bodies away as soon as they started the vaccines. And then we have the kids. This is just in Ontario, where a friend of mine sent me these. He lives in Ontario. And inexplicably taken away. Come on. All of them died from right after they got the vaccine. And they're written up as, well, they just died all of a sudden for no reason. All these kids lost their lives. They were trying to send a message to you. The number of kids in Ontario who died from COVID in the same time period, 0. We're just basically killing our kids for nothing. You know, early treatment has always been the superior approach. So here's an IQ test. Which drug would you take if you got COVID? Drug A, but drug B or drug C? Hopefully everybody chooses drug A. You take the one that our government says not to take, right? So this is the one, right? Look at the hospitalization rate. Look at the death rate. This is the Merck drug. Look at the hospitalization rate. We don't want to put people in the hospital. We should be giving them this protocol. It's been tested over 18 months. This one's been tested less than a year. The FDA and the CDC have no interest in this one. They all like this one, 7.3% hospitalization rate, instead of the one with one person out of 6,000. You know, we never needed a vaccine. We can get to early treatment. Using early treatment, we can get to 0. Uttar Pradesh in India is COVID-free. The vaccination rates are minimal. It's now 11%, but it was sub 10% when they did this. Now you take Kerala, by contrast, in India, still, it's got 3% of the population, and 67% of its inhabitants have at least one vaccination, and they've basically got all the cases. They've got 65% of all the cases in India. This one place with 3% of the population has 65% of the cases because they use vaccination and they don't use early treatment. It's not the solution. I mean, look at in Israel, all-time high. The cases reached an all-time high after the third booster was rolled out. Cases reached an all-time high. It's making people more susceptible. Same thing's happening in Singapore, 80% vaccination rate. And if you look at the numbers here, it's not the way to solve the problem. Look at USA. This is active cases per million population. Okay, and this is just astonishing. 29,000 versus 194 in India. I mean, the US is doing something very wrong here, but nobody seems to care. Now, early treatment benefits: no masking, no social distancing, no more lockdowns, no more mandates. What's not to like about that? Here's the quick summary of this. The benefits: higher relative risk reduction for all variants. Simple prophylaxis protocols can be used. Greater safety. They lower all-cause mortality and all-cause morbidity. They work equally well in all variants. They don't promote escape variants. They don't cause vaccine-enhanced infectivity. They don't risk original antigenic sin or linked epitope suppression that nobody talks about. They don't cause prion diseases like dementia. They prevent long-haul COVID symptoms nearly 100% of the time, and they enable people to acquire what's known as recovered immunity, and which is 27 times stronger than vaccine created immunity. So I'm going to end here by saying the the vaccines basically kill more people than they save. Nobody will debate me or bet me on this. In fact, they won't even agree to a recorded Zoom call. Like, I haven't gotten a single person to agree to just a recorded Zoom call. They won't, because nobody wants to be embarrassed. Early treatments, early treatments can get us to zero COVID. Look at Uttar Pradesh, and we're following Kerala. They're much more effective early treatment protocols than they use in India, like the Fried and Tyson protocol. But Fried and Tyson have been waving their arms to the CDC saying, hey, pay attention, pay attention. You should take a look at this. And the CDC will not return their calls. So my favorite quote is, the one thing that every hospitalized COVID patient has in common, they didn't use a proven early treatment protocol, or they wouldn't be in the hospital. And that's the thing that the press never talks about. They never talk about that all those people have the one thing that all those patients in the hospital have in common, all those COVID patients have in common, is they didn't get treated early with a proven early treatment protocol. And unfortunately, this is not going to change because nobody in America likes to admit they were wrong. And I'm going to end it on that. Also, if you'd like more info, there's an expanded version of this presentation at skirsch.io, the website. And if you just click on the article called Vaccine Resources, it links to everything that was in this presentation. And so if you want to look at any other references, you can do that. And there's a lot more information in the, there's this article called All You Need to Know. And if you look in this article for that presentation, it's an expanded version of this presentation. So
thank you so much, Steve. This was excellent. I'm sure there was much more to share, and we're always happy to jump on a recorded Zoom call with you in the future. So I am happy to introduce our next speaker, Dr. Ryan Cole. He is the CEO and medical director of Cole Diagnostics and serves clinicians throughout Idaho and the nation with expert pathology diagnosis and patient-centered care. Dr. Cole completed his residency in anatomic and clinical pathology at the Mayo Clinic, where he was chief fellow during his surgical pathology fellowship, followed by a year as chief fellow at the Ackerman Academy of Dermatopathology in New York City. As chief fellow, under the direction of world-renowned dermatopathologist, the late A. Bernard Ackerman. Dr. Cole's philosophy is that the patient comes first in every diagnosis, and that the clinician needs definitive answers in order to best treat their patients. Having seen over 500,000 pathology cases in his practice, he's uniquely suited to provide answers quickly and accurately. He's licensed in 12 states and serves patients from Maine to California. Cole Diagnostics, one of the largest independent laboratories in Idaho, was founded in 2004 and has grown from a boutique dermatopathology practice to a full-service anatomic and clinical pathology laboratory with an extensive menu of testing capabilities, including molecular testing, microbiology, clinical laboratory blood testing, and cytology, in addition to outpatient surgical biopsies. You can also pick up a loaf of bread. He has helped perform and diagnose over 100,000 COVID tests this past year. When Dr. Cole is not behind the microscope or discussing COVID PCR specimens, he enjoys creating one-of-a-kind functional works of gallery art, such as tables, bowls, and pens using reclaimed Idaho urban timber, and working on his organic farm near Boise. He's the proud father of 6 beautiful daughters. Thank you so much, Ryan, for being here with us today.
Well, thank you. It's an honor and a pleasure to be here. So like Steve, I'm going to try to fly through some quick information here. I always like starting with a quote by Patton. If everybody is thinking alike, then somebody isn't thinking. And I think that's what we're experiencing this year, is we're not allowed to think differently. And what Steve just shared, I concur with a ton of what he just said. And the challenge is there's not misinformation, disinformation, there's data and information. And people are unwilling this year to look at an alternate view as to what this information and data means. Yes, we're on to a new variant of this virus, Delta. And the concern I have, when we're looking at this vaccine question is, The vaccines were originated for the original Wuhan strain. We're on to Delta. We're many variants later now. So the equivalent of asking people to take a shot right now is like saying to a healthcare worker, hey, you know, it's flu season coming up. We want everybody to get their flu shots. And by the way, we have leftover flu shots in the fridge and freezer from 4 or 5 years ago. Why don't we just give you those? You know what? People would say that's insane. Of course, we're not going to do that. We want this year's formulation. Well, these shots, these boosters, this concept of let's give everybody another shot, it's for a virus that has left humanity back in January and February of 2021. The virus for which these shots was formulated is no longer even in circulation, and Delta acts much differently. So why is Delta different? Well, I'm not going to go through all the science of this, but there's mutations, there's additions, there's deletions, and it changes the shape of the spike. So it has a higher propensity to bind to our cells. And then there's this little furin cleavage site. Because of that, and this was, you know, an engineered cleavage site. This is not something we find in nature. Prior, 10% of cells would get, or 10% of virus would get into our cells. With Delta, about 75% can get into our cells because of this newer mutation. So we're dealing with a virus. The vaccines aren't for this virus, period. They are not for this variant of the virus. They don't work. Their efficacy is essentially zero. If you look at the risk reductions, Mayo Clinic, where I trained, they did a study back in June saying the efficacy of Pfizer was down to 42%. Israel had it at 39%. That was before Delta even started to spread. In order to even get an emergency authorization for a shot, you have to be above 50% efficacy and have efficacy for at least 12 months. These shots don't do that. These are therapies. These are not vaccines. To Steve Kirsch's point, yeah, where are all the autopsies? Dr. Schermacher did an excellent study, and I've communicated with some of those pathologists in Germany. And after some talks I've given, I have autopsy material on my desk at work as well from post-vaccinated deceased individuals. And we're starting to see here in the US, we're not getting that data. The NIH isn't funding true, pure science like they should. Meanwhile, in other countries, they are. The spike itself that we're giving in these shots is a toxin. This was from Ogata et al. At Harvard that showed the spike circulates for several weeks after the shots are given. It doesn't stay in the deltoid, it circulates around the body. And it hones to our receptors and it causes inflammation. So this is the pretty stuff I get to see in the laboratory. On the right-hand side, all that blue, that's inflammation. On the left, you see healthy lung tissue. So these are in post-vaccine injury studies. Here's heart. You hear about inflammation of the heart and the heart sac in children. On the left, all those little blue dots, that's inflammation. It should all be pink. You shouldn't see that blue there. So this is what happens to the hearts of many individuals post-shot. And then on the bottom lower left, you see all this blue. That's scarring. Once a heart is damaged, you hear in the news, oh, it's just mild myocarditis. No such thing. Medically, no such thing. Once you get that density of inflammation, you get scarring. You're scarred for life. So that's cardiac function that's decreased for life. Here you can see damage in the liver. There on the left, all that blue does not belong there. It should be all bright pink. That's inflammation in the liver. Not only does the shot cause that, but we know that the new drug molnupiravir from Merck also can cause that same kind of liver damage. So we're getting these hopeful signals from new drugs when we know there are much safer drugs that have been around for 4 and 6 decades respectively that don't do this to the liver. And we're adding new drugs to the market that we do know does this. This itself is actually post-shot. Ovary, we know the lipid nanoparticles concentrate in the ovary. We're pushing these shots for children. We don't know what the long-term fertility implications are going to be. We have a grave concern for the future of our children. You know, what about safety? You know, to Steve's point, here we are. Again, VAERS, we get criticized for using the only early warning system. So I can say, yes, there are at least 16,000 deaths, 778,000 adverse events reported. It would be one thing if we wanted to criticize VAERS or got criticized here for using it. But if you look at the Eurovigilance data, it's the same, if not higher. If you look at the UK data, it's the same, if not higher. It's not just here that this is happening. So when we get the critics saying you can't quote VAERS, hogwash, because we're seeing the same signals worldwide. These are dangerous, these are damaging. And to, you know, Steve's point, here you see. Again, 30 years of vaccine data combined, all vaccines, and then just this last 9 months. And here you can see on the bottom portion of it, how many of these deaths occur within just a day or two of the shots. a high percentage. And from that Harvard study, we know how long the spike circulates and how long it can cause damage. So all of these other ones down below are approximately associated as well. Here's another thing we keep missing in our society. We're pushing for shots in the middle of a fast spreading virus. We are not emphasizing to screen before giving these shots. Many people are carrying the virus at the time they get the shot. You're pretty much setting them up for an adverse reaction or death if you do that. A high percentage of North Americans have already had COVID. If you've had COVID, you do not need a vaccine, period. That is anti-science. It is, and it always has been, and it always will be. If you are recovered from a virus, you are recovered from a virus, let it be. And Rao, Kammerer, Mathudius, their studies, 3 additional studies, all their studies, 6 studies now show if you've had COVID and get a shot, you are at a much higher risk of adverse reactions. We should not vaccinate the COVID recovered ever. And if we're not screening to see if they're COVID recovered or carrying the virus, we are literally putting people in harm's way. And that is not the oath that we took in medicine. We should not put people in harm's way. It is wrong to not screen people and then to not acknowledge natural immunity is insane. Another thing about the shots, and this is really concerning, immune modulation post-shots. We need to be looking. Before a person gets a shot, we should do all these labs. After a person gets a shot, we should do all these labs. These tell us who's clotting, especially that D-dimer, that C-reactive protein. The troponin tells us heart damage. If employers are going to mandate a shot, every patient should insist on getting this panel before and after a shot. And in the laboratory, we can prove the shot is causing harm. All right, the other thing about immune modulation, in the Netherlands and Germany, they looked at the immune profile. And after giving the shots, they notice a complex functional reprogramming of our innate immune response. What does this mean? This means that there are receptors in our cell, toll-like receptors. These are very important for keeping viruses in check and cancers in check. These are downregulated in these studies. What does that mean? That means after the shot, we have a much higher susceptibility to herpes family viruses, mononucleosis, shingles, etc. In addition to that, the downregulation of toll-like receptor 3 and 4 predisposes you to cancers that may be quiet, that can wake up like a roaring dragon. I'm already seeing this in the laboratory, early signals. We're studying it. We're trying to get together with many labs around the country and the world to do the same thing. This is what the shot does. For how long does it do it? Nobody knows. So why would we be pushing something where we don't know the long-term efficacy and safety? And I've gotten countless calls from oncologists all around the country. I'm seeing these cancers I've been able to manage for years that are slow, smoldering. All of a sudden, it's a dragon, it's a hydra, it's taking off. And these are in the vaccinated individuals. When was the last safety data meeting you got from the CDC, FDA, and NIH? When was their weekly update meeting on which shots are doing better, which are safer? Never. In the last 9 months, never. We are not getting the data from our government. We are not getting weekly briefings. We're not getting monthly briefings. We're not getting any briefings from our government on the safety of these, nor the long-term adverse event signals. These are what I'm seeing in the laboratory. Reactivation of viruses. P53, this is a gene that guards our genome. P53 goes bad, this gene, cancer is the next step. We already know that the S2 of this spike, and the S2 is in the vaccine, that S2 subunit, we know that it binds to this guardian of the genome, P53. We also know that it binds to the BRCA, the breast cancer and the ovarian cancer genes. So we're seeing signals. Interleukin-6 gets upregulated with the shot. Chronic IL-6 can lead to cancer. Dysregulation of other pathways, interferon pathways, JAK, STAT pathways, these can all lead to cancer. We're seeing upregulation of these in the post-vaccinated. That's all there is to it. That is lab science, period. As much as I would like it not to be that way, it's the data, and the data doesn't lie. What about antibody-dependent enhancement? You give a shot, good antibodies forever, bad antibodies forever. So what we're seeing in the vaccinated now is they're carrying higher viral loads of the virus than the unvaccinated or the COVID recovered. Why is that? Because their antibodies bind to the virus but can't neutralize it anymore because it's the wrong shot for the wrong variant of the virus now, period. So we're seeing upregulation of binding, non-neutralizing, which means the vaccinated are going to carry higher viral loads, and are going to be much more susceptible to adverse outcomes like we're seeing in the UK and Israel and Iceland and Singapore and Seychelles, et cetera, at Cyprus, et cetera, et cetera, et cetera, all around the world, Gibraltar, wherever the highest vaccination rates are, the highest per capita death rates are happening now, and the highest increases of viral spread are happening. COVID recovered, naturally immune. Vaccines imitate a portion of a natural infection, period. A vaccine isn't a whole infection, it's a portion of it. So why would we think that a vaccine is better than a recovered COVID patient? It's nonsensical. A COVID recovered patient has a broad, long-lasting, durable immunity. In the SARS-CoV-1 patients, 18 years later, they still have memory, T-cell memory to their infection. They are still immune to SARS-CoV-1. Same thing will happen here. Natural immunity is broad and long-lasting. The other thing a COVID recovered patient has that a vaccinated patient doesn't is a special antibody in their tears, in their nose, in their throat called immunoglobulin A, IgA. This is why the vaccinated are carrying higher loads of virus and are the super spreaders. They don't make this antibody from their shot. The COVID recovered do. This binds virus in the tears, the nose, the throat. This is why the COVID recovered are immune. This is why the vaccinated are still getting breakthrough cases. They don't have this special antibody in their mucosal secretions. Just re-emphasizing other viruses. Look, we've had viruses forever. Once you get them, you're immune to them. Your antibodies will always go down. Don't let people panic you about, oh, my antibodies are going down, my antibodies are going down. Your memory cells, if you keep a good, healthy lifestyle and a good vitamin D level, you will have plasmablasts in your bone marrow. You'll have memory cells in your lymph nodes. Your T cell memory goes up as your antibodies go down. You're going to remember the virus. You know, you may get exposed to a small inoculum of it. Your body will clear it very quickly. You are not, if there were COVID recovered getting COVID again, you would see thousands upon thousands of cases in the medical literature. They are absent because the COVID recovered are literally recovered. The vaccinated are still at risk because Delta is a different dragon. You make antibodies to the whole bicycle with a natural infection, only to the front tire with a vaccine. That front tire gets in a crash, there's your Delta tire. Now you don't have very many antibodies to that bent Delta tire on that bicycle. If you're COVID recovered, you remember the whole bicycle. Early outpatient treatment, to Steve's point, absolutely. NIH recommends nothing, whereas many other foundations support and know that early treatment saves lives. And we, again, look at the Uttar Pradesh, like Steve said, like many other my colleagues will say, we have early treatments that save lives, are much safer, much more efficacious than the vaccine. And we can get through this whole pandemic in a matter of literally weeks if we had the political will to do the right thing and listen to real science and not listen to, any narratives or anything that's out of the science. And with Steve and Dr. Fleming, we'll debate anybody, anytime with data. We have no political bent for any of this. All of this is about what's the data, what's the information, how do we save lives, how do we get ourselves back to normal? That's what this is all about. And I thank you for the opportunity to share.
Oh, I love ending on Baby Yoda. Thank you so much, Dr. Cole. That was so informative. I want to listen to another 2 hours of that. I'm sure there's a lot of research behind that we'd be interested in. If there's access to this PowerPoint or any other information or presentations you have, feel free to pop that in the chat, and Hannah can spread the word.
Okay, thank you.
Thank you very much. So our next speaker is Dr. Stephanie Seneff. She is a senior research scientist at MIT. She holds a BS degree from MIT in biology and a PhD in electrical engineering and computer science, also from MIT. Her recent research interests are on the role of nutritional deficiencies and toxic chemicals in disease, with a focus on the mineral sulfur and the herbicide glyphosate. She's the first author of a recent peer-reviewed publication titled Worse Than the Disease, reviewing some possible unintended consequences of the mRNA vaccines against COVID-19. She also authored a recent book on glyphosate titled Toxic Legacy, which is excellent. If you haven't read it, run out and grab that as well. Without further ado, it is my distinct honor to hand it off to Dr. Stephanie Seneff.
Thank you so much. You can hear me? Okay, so this is the title of my talk, SARS-CoV-2 messenger RNA vaccines, is the risk versus the benefit. And thank you so much for having me. I really welcome the opportunity to present here. So I'll start with an overview. I want to talk about a paper that I wrote together with Greg Nye, Dr. Greg Nye. We published it in May of this year. We did a deep dive into these messenger RNA vaccines and what we found we did not like. And so this paper is something like 43 pages long, lots of references. We titled it Worsen the Disease, Reviewing Some Possible Unintended Consequences of the Messenger RNA Vaccines Against COVID-19. It's open access, so you can read the whole paper to learn a lot more. I'm just going to highlight what we found here. The messenger RNA vaccines are poorly evaluated. They're unprecedented. The technology has been rushed to market and with many, many unknowns, no testing of pregnant women, no testing of old, sick people. They just threw it out into the market, and they're doing the tests right now with the population at large. We saw many potential adverse consequences, much of which we don't know, but there's potential for it, and the science speaks to it. Pathogenic priming, multi-system inflammatory disease, autoimmunity, allergic reactions. We're seeing lots and lots of cases of anaphylaxis in the virus database, which is probably due to the polyethylene glycol in the vaccines. Emergence of novel variants. They keep blaming the unvaccinated, but it's actually the vaccines that are driving the emergence of the Delta variant, for example. Antibody-dependent enhancement, a very big worry that we're already starting to see in Israel and elsewhere, where the vaccine actually backfires and ends up making you worse off than the unvaccinated against the new disease from the variants. Activation of latent viral infections, and that was mentioned elsewhere with the shingles and the Bell's palsy. This is herpes infection. These other viruses are becoming activated because the system, the vaccine is messing up your innate immune system, and that's also been talked about in the other talks. Neurodegeneration, prion diseases. This may be the one that worries me the most because spike is a prion-like protein. We have a big section in our paper on that, and I believe that it's accumulating in the brain and moving towards prion diseases like Alzheimer's and ALS and Lou Gehrig's disease, ALS, Alzheimer's, and Creutzfeldt-Jakob disease. These are all very serious. Parkinson's disease. All of these diseases are related to prion proteins, and spike is a prion and it attacks the brain. I just want to give a little bit of the science behind the vaccines. It's a very fascinating technology, very smart and brilliant, really, in their design. Demonic, I would say, diabolical. And their intent was to design this messenger RNA molecule, which is shown here schematically. The spike protein is in the middle here. You can see all these modified nucleotides up here. They modified all the uridines to make them methyl pseudouridines, which makes the RNA less likely to be broken down. They give it a human 3' end and a 5' cap. These are all human sequences from human proteins carefully selected to optimize for high production of the spike protein and high resistance to being broken down. So this looks like a natural human mRNA. That means it doesn't actually inspire the immune system to react the way it would to a normal viral RNA. And this is why it messes up the innate immunity. And that was talked about in the other talks. It interferes with interferon alpha. And that's what's causing the appearance of these Bell's palsy. Those conditions are being caused by the fact that this vaccine is disrupting your innate immunity due to the fact that it's disguising this viral RNA as if it's a human RNA. And so it contains the genetic code to make the spike protein. It also puts it into a lipid particle that is intended to look like a human LDL particle. And that means that the cells can readily take it up the way they would an LDL particle. So it's not dependent upon the ACE2 receptor. It has this highly toxic synthetic cationic lipid that is added to it to act as an adjuvant, such as what aluminum normally does in other vaccines. Very, very toxic, causes the immune cells to come into the muscle and react. And then they get obsessed with it. We've got to get this spike protein exposed to the B cells because we've got to get these antibodies, because they just see these cells producing this large amounts of this toxic protein. They don't know where it came from. It doesn't look at all like a virus. The polyethylene glycol is what's causing this anaphylactic shock. And then it's carefully engineered to resist breakdown and to produce spike protein at high rates. Now, others have shown this same data. This is the number of deaths reported for various vaccines. And this is organized by vaccine. Diphtheria and pneumonia here are the worst cases besides the COVID-19 vaccines, which are way off the charts. many, and this is for all of history, 30 years of these vaccines versus less than 1 year of this COVID-19 vaccines. This is very interesting because the vaccine is extremely good at making antibodies. It gets your body to make up to 10 times more antibodies to the spike protein than you would get from recovering from the disease. And so they're very proud of this, and this is their goal, and they succeeded spectacularly. The problem is that high antibodies open you up for autoimmune disease. And in fact, there's this study that I show here. It shows that patients with COVID-19, the ones who have the most severe disease are the ones who make the highest levels of antibodies. So the number of antibodies you make is correlated with the degree of effect of the virus on the person. People who have a hardy innate immune system don't need the antibodies in order to recover, and they still can actually protect themselves in the future without these high antibodies to spike. So this is a paper, rogue antibodies could be driving severe COVID. This is showing that self-attacking autoantibodies could be the key to understanding some of the worst cases of SARS-CoV-2 infection. So this is talking about infection, but it's the same thing holds because the spike protein has many segments that are similar to segments of various human proteins that are associated with all kinds of autoimmune diseases. And so when you get these very high antibodies in response to the vaccine, then it sets you up for having autoimmune disease. And I think anyone who already has autoimmune disease, it's going to get worse after the infection. I predict there's going to be a dramatic increase in all sorts of autoimmune diseases in the coming months as a consequence of this massive vaccination campaign. Now, I want to talk about antibody-dependent enhancement. Other people have talked about that as well, and that goes with the breakthrough variants. They kind of go hand in hand. So antibody-dependent enhancement is really interesting, and it's something that has been seen in many different vaccine developments that have failed in the past. The vaccine has the potential to backfire. Non-neutralizing antibodies actually enhance the uptake into the macrophages through these Fc gamma receptors, and that leads to an increase in viral infection replication. The antibody also can cause a cytokine storm. It can cause too great a response to the virus when you get infected, because the antibodies stimulate the immune system to cause excessive inflammation, and that can destroy the lung tissues. And here's a quote from this paper: AIDS has been observed in SARS, MERS, and other human respiratory virus infections, including RSV, respiratory syncytial virus, and measles, which suggests a real risk of aid for SARS-CoV-2 vaccines and antibody-based interventions. And then another quote from this Cardozo paper: the absence of aid evidence in COVID-19 vaccine data so far, and this was quite early, does not absolve investigators from disclosing the risk of advanced disease to vaccine trial participants, and it remains a realistic non-theoretical risk to subjects. Now, this is just talking about the trials, but now we've just done this for the entire population of the globe, and we're asking them to trust us that this isn't going to happen. And yet we are starting to see evidence that it is happening. This was an interesting paper that we referenced and talked about in our paper. This was a cancer patient, and this patient was being treated with immune suppressing drugs. And then they caught COVID-19. They ended up in the hospital. They stayed in the hospital for 101 days. The whole time they were infected, they were shedding RNA and had to be kept in an isolation room. After 101 days, they died. And they were given antibodies from people who had recovered. So they were being given antibodies from the plasma of recovered patients, in the hope that it might help to them to control the virus. But in fact, the antibodies weren't sufficient. The virus mutated wildly in the course of those 101 days. They monitored exactly which version of the virus did this patient have over time. And they found that by the time they died, they had a dominant variant that had 12 different mutations in the spike protein. And so the virus has a tremendous opportunity to perfect itself against antibodies when it's being seen, receives these antibodies in the context of a person who can't fight the virus off. Immune compromised person getting a vaccine is going to be exactly this situation. And I think it's going to it's what's caused the emergence of all these variants. So this is just showing all the variants that were emerging over time from March 13th up to July 17th. You can see this huge growth in Delta in these few months over here after we have a substantial vaccinated population. And now it's over 99%. This was in July, 83% of the cases were Delta. Now it's basically all the cases. And interestingly, they've studied Delta. They find it binds less well to the neutralizing antibodies, and it binds better to the facilitating antibodies that are going to cause antibody-dependent enhancement. And so this is a very important paper that really was revealing to me, because it shows how the response to the virus when you get sick is so different from the response to the vaccine. As people have said, the vaccine has only the spike protein. The virus has several other proteins, and some of its internal proteins are very stable. They don't mutate quickly, even from other cold viruses. And so we have T cells that are able to remember those internal proteins, and they can last for up to 17 years. They can remember. And so when you get the Delta variant, it still has the same internal protein, so that these guys still work. They can still do their job. Whereas the spike protein antibodies that are produced by the vaccine no longer work, because the variant has managed to mutate its spike protein and get out of a jam. And so what's basically happening is that the vaccine completely loses its effectiveness to the variant, the Delta variant, which has intentionally changed its shape of its protein in order to avoid those antibodies. And so the vaccine is useless. And the natural infection still works just as well for the Delta variant, because these B cells remember those stable proteins. So you saw this chart in one of the other presentations. Israel was doing very nicely after they got this massive vaccination program early on with the Pfizer vaccine. They had a nice period in here, but then now they're sort of in big trouble. They were the second highest infection rate in the world at their peak in August, September timeframe. And so, this quote says, unlike previous epicenters of infection in Israel's crowded, less vaccinated, ultra-Orthodox communities, this scourge primarily took hold in the well-vaccinated middle-class suburbs. So this is very disturbing, because it's just starting to show aid. And of course, it's the Delta variant working its way out from under the vaccine. This is an interesting paper that did a lot of data analysis. The blues and the reds are males and females. This is 42 days after the first vaccine, and then 210 days is about 6 months after the first vaccine. So you have the Delta variant here, a very dramatic drop in the antibody response, effectiveness against Delta over that 6-month period. And so the Pfizer vaccine is particularly susceptible to loss of robustness against the virus over time. And so that's why Pfizer is rolling out all these booster shots now. So this one shows a large-scale study of antibody titer decay following this Pfizer vaccine or infection. And so the infection on the bottom, you can see that the antibodies are surviving over time, very, very slow decay, whereas there's a much higher slope here. With the vaccine, you're going to get down to where the antibodies are no longer effective after several months. And this was an interesting paper as well. Each of these dots is a country, and it's got a scale of the percentage of the population that's fully vaccinated. You see, you have a bunch of people here, countries here with zero vaccination and zero cases of COVID-19. Very interesting, this population. I'm very curious as to how these countries have managed to avoid this epidemic. Israel's up here, so it's a highly vaccinated population with a very, very high infection rate. And the general trend is towards more vaccination, more infection. It's quite interesting. Each of these dots is a country. And it really does not give you a good feeling about why you should be vaccinating the world's population when you see data like this. Outbreak in Israel, in an Israeli hospital, very, very interesting here, July 2021. There was an index patient who was fully vaccinated. They came into the hospital and they didn't realize they had COVID, and then their roommate caught COVID from them, and then it spread out over the entire population. A quarter of the patients eventually tested positive for COVID, as well as a bunch of the staff and family members as well. And 39 out of the cases were fully vaccinated. Median time of 25 weeks. So that should have been, really good for protection, but it wasn't. So several transmissions occurred among people wearing face masks. There were 5 deaths, there were 14, and well over half of patients became very sick, even though they were fully vaccinated. There were 2 unvaccinated patients, and both of them had mild disease. And this was a warning about waning immunity over time. So myocarditis and cardiovascular disease, here's the big picture. Messenger RNA vaccines are causing inflammation in the heart of young people who have nearly zero risk of dying from COVID. And that can lead to permanent heart damage or even death. And so people have talked about the S1 unit of the spike protein. Very, very interesting how it can detach with this furin enzyme. It becomes detached and it goes freely, and it goes and binds to ACE2 receptors and disables them. This is really critical. It does it in the heart, and it also does it in the brain. And it can do it in the brain in association with Parkinson's disease. It can wipe out the ACE2 receptors in the substantia nigra, which is where Parkinson's happens, damage those neurons and cause Parkinson's. So I think Parkinson's is another thing that's going to show up in higher, we're going to have more people getting it younger following these vaccines. Now that's kind of a digression, but the heart problem is ACE2 in the heart. There's many ACE2 receptors in the heart. They get stuck with S1 that disables them. This causes upregulation of angiotensin 2, which then induces inflammation, which is myocarditis, and subsequently cardiovascular disease. And S1 has been found in COVID-19 patients long after the virus is cleared. And it's believed to play a critical role in what's called long haul COVID, where people have persistent symptoms in the brain after they recovered from the disease. And it's also been found in the vasculature after vaccination, which you would expect because the cells are exposing it on their surface, and then the S1 is being snipped off by the furin enzyme. So this is a paper that showed 11 out of 13 healthcare workers had detectable levels of the spike protein and especially S1 in their blood plasma as early as 1 day and up to 28 days following the first messenger RNA vaccine. The peak was at 5 days after the vaccine. And this is showing that S1 alone by itself is toxic to mice. Spike is the most toxic part of the virus. And so the vaccine is just making your cells make a toxin, make lots of a toxin and expose your entire body to this toxin. S1 alone caused COVID-19 like lung symptoms in mice that were humanized with ACE2 receptors. It's pretty amazing what they can do with this biotech industry, very sophisticated. So they give these mice human ACE2 receptors and they show that S1 can cause the classic symptoms of COVID-19, actually, with the cytokine storm and the impaired barrier function. SARS-CoV-2 messenger RNA vaccine associated myocarditis in children, ages 12 to 17. This is a national database analysis. This paper made a really good case for the fact that the vaccine is absolutely foolish for these kids because they showed that the rate of myocarditis after 2 shots of Pfizer was 162 cases per million in boys 12 to 15 years old. And 86% of them required hospitalization. It could lead to permanent damage and heart failure. And they computed the risk of a healthy adolescent being taken to the hospital with COVID-19 to be only 44 per million in the next 3 months. So there's a much higher case of probability of getting hurt by the myocarditis from the vaccine for these children than there is to get even into the hospital with the disease. And this is one of these charts. I mean, all of these charts look like this with all these different symptoms, but myocarditis in VARS, this is over from 2010 to 2020, all the vaccines together. And then here's 2021. It's clear, there's an obvious signal here. These vaccines are causing myocarditis. And Sweden and Denmark have decided to pause the use of the Moderna vaccine for all children and young adults as a consequence of this myocarditis problem. So in conclusion, the messenger RNA vaccines against COVID are neither safe nor effective. Reports of adverse reactions are much higher than for any other vaccine. The vaccine induces exposed cells to produce large amounts of spike protein, which is toxic. It causes myocarditis in young people who are very safe from COVID. It induces a very high antibody response, which is dangerous because it can cause autoimmune disease. Vaccine-based immunity fades quickly over time, so you're going to probably end up getting booster shots maybe every 6 months. And each booster is going to be another risk of having serious outcomes. The vaccines may be responsible for the rapid emergence of vaccine-resistant mutants, and antibody-dependent enhancement is a real risk that may make the vaccinated susceptible to worse symptoms than the unvaccinated. And thank you for your time.
Thank you so much, Dr. Seneff. Just brilliant work. Thank you for bringing this to all of us today, and to Dr. Cole and Steve Kirsch, who are hopefully still with us. I know that it is about lunchtime. I ask you to bear with us for a few minutes because I have a feeling that we're going to have a few questions after this panel. So what we'll do is take about 10-15 minutes and answer some questions, and then we'll break for lunch. And I see Rep. Durant has a question right out of the gate. Go for it. It's okay. That's okay.
I do have just a couple quick questions. Actually, I have a ton of questions. This was fantastic information. And I think all the panelists here, I'm kind of a data guy, so I like all this technical data. But so I'll try to keep them brief, but I have 2 quick questions.
Sure.
Is the Delta variant more deadly than the original? That's the first question. Thank you. And the second question I would have is if, for those people that are vaccinated, I know Dr. Cole had mentioned, I look at that analogy of the bike with the warped tire. For those people that are vaccinated and get the Delta variant and recover, will their immunity be as good as now somebody who didn't get the vaccination but recovered from COVID to begin with?
Great. Did everyone?
Yeah, I got
that
both those
question and
questions.
also online because I can repeat them.
I got both those questions. So Delta technically is not more deadly. If we look at other countries, in parts of the UK, it was 1/10 to 1/20 as deadly. In parts of India, it was about 1/7 to 1/10 as deadly. Here in the US, we're seeing it's been a little different. And the reason being, we're metabolically unwell as a nation compared to many other nations. We have a lot more predisposing comorbidities. So we're seeing a slightly higher death rate from Delta than other nations have seen, unfortunately, here compared to much of the world. Is that because other nations are using early treatments and stopping the virus, and our political unwillingness and our therapeutic nihilism? Perhaps. Are we giving drugs that kill the kidneys in the hospital, like remdesivir? We are. Are some of the death rates from some of the treatments we're giving? Probably, in the hospitals instead of using the early outpatient treatments. So yeah, we're seeing, I don't know the total data for Delta here compared to other nations, but it doesn't appear that we're faring quite as well. And then your second question in terms of, remind me what second one was.
The second question was about recovery for someone
yeah.
who might have received the vaccination and had Delta.
So this is
after.
a very good question. We don't have long-term studies on this yet, because after the shot, we already know that we've modified and modulated the innate immune system based on the downregulation of those receptors I mentioned. So what we do need is some long-term studies in the COVID recovered that haven't been vaccinated, the vaccinated who got COVID and got recovered, and we need to do cell comparatives. We need to do cell marker comparatives. I would hypothesize that the immunity would be broader and better in somebody who had a vaccine, got Delta, and now is recovered. I would hypothesize that it should be a good broad natural immunity. There may be aspects of it that are slightly weakened comparatively, but I'm only hypothesizing. We don't have the data to prove it yet.
Great, thank you. Anyone else with a question for this panel, or anybody on Zoom or live stream have any questions in there? Yes, Lynn.
I was just going to make a quick comment because Steve, I saw an interview where you talked about my doctor friend, that neurologist, I believe, that had 2,000 reactions to COVID, to the vaccine, but didn't have the time to put it into the VAERS. Which I don't know if you want to comment on that, because I thought that was very impactful.
Sure. So there's a neurologist that I know. She doesn't want her name to be used because she's worried that she'll lose her license for speaking out against the vaccine. And by the way, this is why you never hear doctors speaking out about the vaccine, because they don't want to be ostracized by their peers, marginalized, or lose their ability to practice medicine. So in America and in other countries, doctors are forbidden to talk publicly about any objections to the vaccine. So in this particular case, we have a physician who's been in practice for 11 years. And she has, her practice is large. She's got 20,000 patients. This year, she has 2,000 who had severe enough reactions to the vaccine to report them to VAERS. She got frustrated after she reported 2 of them. And she said, look, I'm wasting my time here. I'm entering all the data and it crashes and I have to do it again. I'm just not going to, even though I know I'm supposed to, I just don't have the time for this. And even if I paid someone like, $25 a patient times 2,000, that's an extra $40,000 that's out of her pocket that she has to pay for in terms of time. And so, if it was 1 patient or 2 patients, but this is 2,000. And I asked her, so how many, You've been in practice for 11 years. How many times have you needed to report to VAERS in the past 11 years? The answer is 0. And I've asked there's another doctor in Canada that I know, and he doesn't report to the VAERS system, he reports to the Canadian health system. And he's been in practice for 29 years. Never needed to make a report on vaccine safety before to the Canadian authorities in 29 years, and 0. And this year he needs to report 25. And he's reported 25, and they rejected most of them when he started reporting them, but now that they're starting to accept them.
And
Thank you.
to Steve's point, the boards of medicine have been weaponized against physicians. I've had hundreds upon hundreds of political complaints against me for just sharing data and science. Another one from the Idaho Medical Association just yesterday, that's in the newspapers, for just trying to share data and save lives, period. It's been weaponized.
Mhm. Mhm.
You know, another issue as far as reporting data on this, if you have an adverse drug event to measles, mumps, and rubella, or to the diphtheria tetanus vaccine, there's a code, there's a CPT, a computerized code to report that. There is not a computerized code to report an adverse event to any of the SARS-CoV-2 vaccines, which means there's not going to be a data bank to collect to, even for the people who love to go back and retrospectively write papers, to collect that, number one. Number two, I've actually tried to call in on the data bank, and I, on the physician line, get a recording that tells me, please, if I have a message to leave, please call another number. It doesn't even give you a place to leave a message. And when you call the second number, there is no place to leave a message. It's just a recording. And then thirdly is the issue of actually reporting it into the data bank. But I think all the questions aside from how many people are on VARs and, you know, how many people have died, again, I guess I'll beat this to death. After 25 people from swine flu vaccine, and I think 52 total, we pulled the plug, and mainstream media did a documentary on 60 Minutes to address the lies that were being produced. So, you know, when everybody starts quoting numbers, I think when we got over 25, we hit our pivotal point. So it doesn't matter whether we've got, you know, 14,000 in the US or 40,000 in the US, another 15,000 in Europe. I think that's a substantial number of people. When we've got, you know, 5,000 or 6,000 myocarditis resulting from the inflammatory thrombotic response to the virus due to comorbidities, or in vaccinated individuals simply because of the antigenic load, we've got a problem. And in medicine and in science, the typical practice has been, when you're doing something that causes a bad outcome, you stop doing it.
Thank you very much. So we have one, we'll take one question from, I think this is from the live stream or the Zoom. Was there any evidence of menstrual cycles being affected after vaccination in your experience in practice with women?
Clinically, yeah, there are countless reports, and there are multiple mechanisms that could be causing this. Number one, lipid nanoparticles do hone to the ovary, as Stephanie mentioned, can cause inflammation there. That can, especially with polyethylene glycol being something that 70 to 80% of Americans already have antibodies against polyethylene glycol. So we know we have a high allergic response to that particle as well. So yes, women that get the shot are certainly getting an inflammatory response in the ovaries, causing dysmenorrhea, adverse bleeding, etc. Additionally, when the ovaries are stimulated like that, the body can trigger you to secrete pheromones. So like women in a college dorm will tend to cycle together. So if one woman gets a vaccine and she's around other women, that pheromone can induce menstrual cycles in women that are around that vaccinated individual. Additionally, we know studies out of Wuhan showed that the virus proper could be secreted in sweat and whatnot in the body. So we know that the spike can be secreted. Now, when the body starts to replicate spike, is there enough spike to be shed and aerosolized and trigger immune reactions in individuals around them? We're still looking at the science on that. Is it happening? You bet. I believe the women that tell me that, and they tell me that. And I'm seeing Again, in the laboratory under the microscope, unusual numbers of hyperplasias of the uterine lining. I'm seeing a marked increase of uterine cancers over what I see year to year. And so something is wrong, period.
Mhm.
Yeah,
Indeed.
and let me just add really quickly that people can get these menstrual effects from a vaccinated person. So
Correct.
we've had people, there's one case for a woman who's living with a man, and the woman started getting menstrual issues, really strange menstrual issues. And she had no idea that her male roommate was vaccinated. And so she asked the question, hey, did you just get vaccinated? And he said, yeah, 2 weeks ago. And then she said, oh, that explains it. And so she didn't know. So it's not psychosomatic, and it's not women in the same room sharing menstrual cycles, which has been sort of known to happen. So this is a male vaccinated person influencing a female person who is not vaccinated. And I paid to have the cytokine study done by Bruce Patterson of this individual. And indeed, she had elevated cytokines, not quite to someone who's had COVID, but almost to the level that she would have been classified as a long hauler, just by being in the same room of a newly vaccinated person.
I'll tell you, Greg Nye and I touched upon this topic in our paper. And what we think is happening is we know that, in fact, the RNA accumulates in the spleen, and the immune cells at these centers in the spleen they're making all this spike protein, and they're packaging it up inside exosomes, and they're releasing those exosomes, and those exosomes are traveling along the nerve fibers, along the vagus nerve to the heart and to the brain. And that's how you're delivering the spike protein to those organs and causing these symptoms. But also they can get delivered to the lungs, and they can get released from the lungs. It seems very clear to me that you would have exosomes produced by the immune cells that are burdened with all this spike protein they're making, and they can't stop making it. They're going to release it in exosomes and deliver it out through the lungs, and then somebody else can breathe it in. I think that is a very plausible mechanism by which you could deliver the spike protein to somebody nearby.
I think also it's important for people to understand that ACE2 receptors are diffuse throughout the body, and they are also very highly concentrated in ovarian and testicular tissue. So, when everybody's trying to figure out why in the world the spike protein would attach in these tissues, it's attaching to where the receptors are. And we also know, as was mentioned briefly, that the spike protein very eloquently crosses over the blood-brain barrier. I mean, this spike protein attaches more than just with the ACE2 receptor. It's the glycoprotein 120 component that sits on the sialic receptor wrap that holds it in place. So it then attaches to the ACE2 receptor. It then is begun to be incorporated by the TMPRSS2 receptor, and then it's cleaved with the furin cleavage site, and then it goes through the neuropilin-1 receptor, particularly in the brain, which is why there's olfactory neuropilin, which is also part of the inflammothrombotic response pathway that I first talked about in 1994. So it is not a surprise that these tissues are being affected, and it shouldn't come as a surprise to anybody.
Great. Thank you very much. So transmission is something we definitely can look more into and have a whole other talk about. First of all, I want to just say thank you very much to everyone who is here so far speaking on our panel and who has yet to speak. And that is our break for lunch. We would love everyone to be back by 1:30 when we're going to get started again. So take your lunch, enjoy your break, and thank you again to everyone who's spoken so far. It's been fantastic.